Hi, this is Michael Altos, and we are finishing our discussion of blood, and this is recording part 13. Now we're going to discuss a number of different hemostasis disorders. Let's start with the thromboembolic disorders, DVT, PE, venous thrombus embolism. Remember, a thrombus is a clot that develops in a blood vessel. An embolus is a thrombus that breaks free and flows with the blood. A thrombus can block flow to the brain or the kidneys or other organs if it's in the arterial side. In the venous side, a thrombus can flow into the lungs, causing a pulmonary embolism. Thrombus formation is encouraged by a roughened endothelial surface or if blood flow becomes very slow. Congenital causes of thromboembolic disorders include factor V Leiden, which is basically resistance to activated protein C. This is the most common hypercoagulable mutation, occurring in about 5% of Caucasians, and it is autosomal dominant. Factor V becomes resistant to degradation by activated protein C. Patients can also have protein C and protein S deficiencies, which leads to venous clotting. The treatment is anticoagulation therapy, same for factor V Leiden. Just one reminder, there is something called warfarin limb necrosis, and this occurs when you start warfarin before the patient is therapeutic on heparin, because protein C and protein S are the first factors to be affected by warfarin. So actually, even though warfarin is an anticoagulant, patients may develop clots when you initiate it, if they're not also on heparin or something else. Patients can also have antithrombin 3 deficiencies or prothrombin mutations leading to clotting. Those are congenital disorders. Patients can also have acquired disorders. There are many risk factors for forming clots, including inactivity or immobilization, even as short as on a plane ride, as we've seen. Malignancy, oral contraceptives, and estrogen, as well as pregnancy, are all hypercoagulable states. The antiphospholipid antibody, lupus anticoagulant, anticardiolipin antibody are all factors that increase risk of blood clots. The antiphospholipid antibody is found in patients who have Guillain-Barré syndrome, lupus, migraine, scleroderma, Sjogren's, Wegener's, a lot of these sort of inflammatory and potentially autoimmune diseases. It's called the lupus anticoagulant, but first of all, you don't have to have lupus, and second of all, you're not anticoagulated. In fact, they often have an elevated PTT, but they aren't actually anticoagulated. In fact, they have increased risk for clotting, for thrombus. So it's called an anticoagulant because their PTT is elevated, but clinically that's not what we see. This would be a good example of where a mixing study is helpful. So their blood shows an elevated PTT, but when you mix it with regular control plasma, the PTT still remains prolonged, which tells us that there isn't anything wrong with their plasma. In fact, they've got this substance, this lupus anticoagulant, elevating their PTT. Hyperhomocystinemia, due to different congenital mutations or vitamin deficiencies, can also lead to thromboembolic disease. Now let's talk about primary hemostasis, which is the platelets. Von Willebrand's disease is the most common hereditary bleeding disorder, affecting about 1% of the population. They may have bleeding in their mouth, nose, heavy periods. Studies may all be normal, including PT, PTT, and platelets. Often the treatment for von Willebrand's disease may be DDAVP, desmopressin, which cleaves von Willebrand's factor from factor VIII. You see there are several different types of von Willebrand's disease. Type 1 is a deficiency in von Willebrand's, and it's the mildest and most common. Many people don't even know they have the disease. It's autosomal dominant, and they're not absent, but just deficient on von Willebrand's. So DDAVP will cleave more von Willebrand's factor from factor VIII and make it available. There are many different types too, and I don't think you need to memorize these. You just need to be aware that there is one type of von Willebrand's disease where DDAVP will actually cause thrombocytopenia. And finally, type 3, which is the rarest and most severe. These patients benefit not from DDAVP, but from factor concentrates of von Willebrand's factor. Hemophilia A and B are both X-linked recessive diseases. Hemophilia A is due to a decreased level of factor VIII. these patients may still have normal von Willebrand's factor levels. Patients present with deep tissue bleeding, hemarthrosis, which is bleeding into joints, and hematuria. We expect to see a prolonged PTT, but a normal PT and bleeding time. Normally, the factor VIII serum concentration is 100 to 200 international units per deciliter. Patients with mild disease will have anywhere between 5 and 40% of normal levels. Moderate is defined as 1 to 5% of normal levels, and patients with severe disease will have less than 1% normal levels. The treatment for hemophilia depends on the severity of disease. In mild disease, DDAVP may help because it will cleave factor VIII from von Willebrand's factor and therefore increase factor VIII serum levels. Otherwise, specific factor concentrates like recombinant factor VIII would be the ideal treatment for patients who have hemophilia A. Chronically, these patients are treated with enough recombinant factor VIII to achieve a goal of somewhere above 1% of normal. Ideally, about 3% is sufficient for normal daily living. But for patients who are having surgery or who sustain a traumatic injury, usually we administer 50 units per kilogram of factor VIII with a goal of achieving somewhere between 50 to 100% of factor levels. The factor may then need to be redosed every 8 to 12 hours. Also, in cases of urgent bleeding, when factors are not available, bypass treatment can be initiated using prothrombin complex concentrates or factor VIIa. Hemophilia B is pretty much identical to hemophilia A, except it involves factor IX. We see this in patients with Ashkenazi Jewish descent, and of course they're treated with factor IX instead of factor VIII. Remember, factor IX has a much longer half-life, and we treat them to levels of 50 to 100% of normal values. There is something called hemophilia C, which would be decreased factor XI. It's autosomal recessive and it's very rare. Patients can theoretically develop acquired hemophilia, where they have antibodies to factor VIII. And hemophiliacs who have been exposed to these factor concentrates for their whole life may develop factor inhibitors and antibodies to those factors. This happens in about 30% of hemophilia A patients. Disorders of secondary hemostasis are varied. Amyloidosis patients may have amyloid protein absorbing factor X, so it can't be used, but you can be deficient in virtually any coagulation factor. Those are all congenital disorders. Let's talk about some acquired disorders. So patients can have acquired disorders of primary hemostasis. Thrombocytopenia, where the platelets are either not produced, they're consumed, they're destroyed, they're diluted, they're sequestered. They can also have adequate numbers of platelets, but they have dysfunction due to uremia, drugs, or other substances. Acquired disorders of secondary hemostasis could include vitamin K deficiency, which affects factors 2, 7, 9, and 10, as well as protein C and S. Vitamin K comes from leafy greens and is also synthesized by the bacteria that live in our intestines. So antibiotics could cause vitamin K deficiency, as well as liver disease, TPN, hyperperistalsis. We treat it with oral, IV, or IM administration of vitamin K. Liver disease, of course, can affect not just your platelets, but your whole coagulation system and your fibrinolysis. So we can see not only vitamin K problems, but thrombocytopenia, platelet function problems, decreased production of factors, but also decreased production of anticoagulants, decreased fibrinolysis. These patients are in a low-grade version of DIC. Their PT and PTT may be terrible, and in fact, clinically, their coagulopathy isn't as bad as the labs make them look. They may even still have a big risk of thrombus and thrombosis, as well as bleeding. Patients can also develop immune alloantibodies to clotting factors. DIC is disseminated intravascular coagulation. It's also called consumptive coagulopathy, and you should think of it as a disorder of uncontrolled bleeding and clotting. The clotting occurs because they have pathologically activated their coagulation. They're not degrading clot normally, and so they get thrombi deposited throughout the circulation, especially in the microvasculature. So they get ischemia of the kidneys and the lungs and things like that. At the same time, they're also bleeding. As they form all of these clots everywhere, they're depleting their factors and their platelets. Platelets get entrapped, they get consumed, they deplete their coagulation factors. They've also activated their fibrinolytic system, creating these fibrin degradation products, which further inhibit clotting. Patients with DIC often are experiencing some comorbid condition like sepsis, obstetric complications including amniotic fluid embolus, fetal demise, placental abruption or preeclampsia. We also can see DIC in patients who have trauma or burns, malignancy, hemolysis, acidosis, or hypoxia. Clinically, we see petechiae, ecchymosis, and other examples of bleeding. Lab studies may show elevated PT or PTT. We may also see thrombocytopenia. Fibrinogen levels will be decreased, and FDPs and D-dimer will be increased. In these patients, the fibrinogen can be normal sometimes, but keep in mind that fibrinogen should be elevated during situations of injury or stress. Scoring algorithms exist which help quantify DIC based on platelet count, PT, fibrin degradation products, and fibrinogen levels. The treatment for DIC is primarily to treat the underlying pathology. In addition, try to keep platelets above 10 to 20,000, keeping them above 50,000 if there is active bleeding. Clotting factors should be repleted using either FFP or factor concentrates. Cryoprecipitate may be useful because it allows us to give fibrinogen and factor VIII without giving a lot of fluid volume. Our goal would be to keep fibrinogen above 100. Some studies have suggested that anticoagulation may be helpful in order to prevent arterial or venous thromboembolism. That's it for our discussion of coagulation. Please let me know if you have questions about any of the material.